our research speaker series. We're going to wait another minute or two and allow all the participants to join. Thank you for being so punctual. Okay, I think we're going to get started. So hello, everyone, and thank you for joining us today for this session of the Susan Samueli Integrative Health Institute's research webinar series. I'm Shaista Malik. I'm the Executive Director of the Susan Samueli Integrative Health Institute and a professor in medicine. Before we start, I want to review a few Zoom housekeeping items. The session is being recorded. We will send all registrants the link to the recording, and we'll post the link on the event webpage for the Samueli Institute. Everyone will remain muted to limit distractions, but please communicate with us, including submitting any questions in the Q&A feature at the bottom of your screen. And so we may take an opportunity to take questions about halfway through, but we will definitely be taking questions at the end or as time allows. So the Samueli Institute is committed to whole person health, research, education, and clinical care. Our interdisciplinary researchers are dedicated to exploring the science of disease prevention and treatment. And we bring this series to you to share the promising integrative health research that's occurring through the Institute's pilot studies grants, as well as the Samueli Scholar Awards. And so our wonderful speaker today is Dr. Sean Young, who's one of our inaugural Samueli Scholars. He's the Executive Director of the UC Institute for Prediction Technology and a professor here at UCI with joint appointments in the Department of Emergency Medicine and the Department of Informatics in the Donald Bren School of Information and Computer Science. The UC Institute for Prediction Technology brings together researchers across UC campuses from a wide variety of disciplines to study how social, big data, machine learning, and data mining can be used to predict real-world events. Dr. Young is also the author of a best-selling book, Stick With It, a scientifically proven process for changing your life for good. He's also a member of the board on population health and public health practice within the National Academies of Science, Engineering, and Medicine. And he holds several grants from NIH for his groundbreaking work. Please welcome Dr. Young with me. Thank you.
Thank you so much, Dr. Malik, and for the Samueli Institute for both funding and for the work on campus. I'm going to share my screen now. Okay. All right, before I get started, just a conflict of interest statement. As Dr. Malik mentioned, research funding to the university from National Institutes of Health and University of California, Intel. I also advise some startup technology companies and have royalties. So I thought for this talk, I'd start a little differently than with other talks because it's integrative health. And what's really exciting to me about integrative health in working with others and studying it is just the breadth of people's experience. You get to work with people who have just a range of different experiences. And so I thought it might be helpful before going into the research for you to know a little bit about me and the background and how I got here. So I started off, you can tell even from my background, I started off, I love music. I studied ethnomusicology at UCLA, where I just had a deep love for music and was fortunate to be able to have private lessons with different instructors around the world for my area of study. Then I went to graduate school in psychology. This was at Stanford University. Went to graduate school in psychology and also health services research in medical school. At the time, I was also working for NASA Ames Research Center, building applications to test for VR, virtual reality, and for astronauts. Did some work for Cisco Systems, doing some early data work. Ultimately was interested in entrepreneurship. So this was the time that entrepreneurship in the Bay Area was really growing with tech, and so wanted to combine the work in psychology with technology, and was able to write about it, and then came to UCLA as a postdoc in medicine, in infectious diseases and global health, before arriving here at UC Irvine, where originally I'm from Orange County, so it was really exciting to come back home. All right, so in this presentation, I'm going to talk about 4 different topics. Most of the time will be spent on the first 2, especially this first one. The 4 topics are, first, psychologically driven artificial intelligence approaches on social data, and how we can use data from social technologies to help detect problems and progress. And within integrative health, this will be at the biological, behavioral, social, and environmental levels. Then we'll talk about online support and behavior change technologies. Third, I'll talk about the implementation considerations of this. And then fourth, I'll just touch on a slide of new ideas on music and health. So coming back to that initial music background that I mentioned, I'm excited to explore. And I'm going to go through these quickly, but you can stop me midway through if there are questions. Okay, starting with artificial intelligence and social data. Back a few years ago, this was in 2015, you might have heard or might remember there was a sudden outbreak of HIV that occurred in a rural area of Indiana. So in this area with just about 4,000 people, they suddenly had about 200 cases of HIV, which is an epidemic. And this was before COVID. We know similar things happen with COVID. And in this case with HIV, it started off where there were 2 or 3 people, let's say, who came into a clinic, came into an HIV clinic, or came into the local health clinic and tested positive for HIV, and their information was then reported to the county, which gets aggregated, reported to the state. And then more people started coming in, another 3, another 5 coming into different clinics in the area. Their information gets reported to the clinic, then to the county, then to the state, ultimately to the CDC. But this process of waiting for people to come in and test, collecting their data, reporting it, then the clinic sending it to the county, to the state, aggregating and to the CDC, takes time. And so pretty quickly, more and more people started becoming infected with the virus. And if we could have had faster surveillance, if we could have avoided that lag time, and especially if we could have predicted some of these cases, then we could have prevented transmission from occurring. And so what I wanted to figure out was, how can we use some of the technology and artificial intelligence and statistical methods and new data sources to address a question like this, for example. So I'll start with this. I love this book and this movie. And normally if I had more time, I have a nice interactive experience with the audience where we talk about this and people have different perspectives on what this book or movie is about. I love hearing it as a psychologist. But just for time's sake, so this book, Moneyball, or movie Moneyball, here the movie was played by Brad Pitt, and Brad Pitt was the manager of the Oakland A's, Billy Beane, and the A's weren't doing well as a team. And he didn't have much money, and he decided he was going to put his money into hiring a statistician, played by Jonah Hill here. And the statistician helped to use statistics to put together a winning baseball team, and it worked. The A's went on and did really well, and it was successful. So I think it's a great example of statistics and how to make predictions with data. But this happened back more than 20 years ago now. And so since then, we have more data. We have more data than we've ever had before, and it continues growing each day. We have newer statistical methods, and so we can do a lot more than we could back then, and we can apply it to different areas. So, for example, every day on Twitter, there are 500 million tweets being sent every day. Now, I think 400 million of these feels like coming from Elon Musk talking about anti-vax information, but there are a lot of tweets that are happening every day from people around the world. There are 55 million status updates happening on Facebook. And these are just the big social media sites. If we turn to what we consider the smaller ones, every day 700 million snaps sent on Snapchat, 70 million perfectly filtered Instagram photos being sent. So there's a lot of data happening in social media. And the question is this just meaningless information that people are posting, or is it something that can link back and be informative in terms of public health and medicine, integrative health? And so we started searching for information, and we found that people would share all kinds of personal information on social media. Here they're telling you that they're drunk driving. They'll tell you about drugs that they're using. This is all public information, completely publicly available, sharing with the world, telling you about substance use. They'll tell you personal things about experiences. They'll tell you about their experiences with health conditions and things relevant to integrative health, like meditation and how it can be useful for anxiety and depression. So we started studying these forms of data, social data, which I consider data that provides information related to psychology. It can provide information about people's attitudes, their behaviors, their social environments, and it includes social media data like tweets. It includes Google search data. So here's an example of someone searching for "can you die from," and that reveals something about their intention, something about their psychology, and you can get that from looking at search data. Wearable device, internet search, mobile app data, mobility, movement data. All these are forms of social data that link back to psychology. So if we go back to this example from the area in Indiana, the question is, can we use social data and these newer forms of statistical analyses or data science approaches to help address problems like this? Now, to me, I originally, as I mentioned, so I studied social and behavioral psychology. I'm an interventionist, and my ultimate interest is intervening and changing, improving people's health behaviors. But oftentimes, we don't know how to intervene, we don't know where to intervene, we don't know among whom to intervene. And so by filling in the gaps with data, we can help inform future interventions, and we'll get to now how to do that. So we started off, I'll go through some of the earliest, starting with one of the earliest studies. We started off pulling data from Twitter, and then being able to use, just at that time, pretty basic machine learning methods. So for example, in one of the first studies, we quickly collected 550 million tweets from around the world. And then we identified the ones that were geolocated, they're tagged, because some tweets have people say where they're tweeting. 2.1 that were originating from the United States. And then we manually went through 10,000 of them to ensure they had keywords related to either sexual risk behaviors or substance use related to HIV. And so we manually reviewed those. And so examples of the sexual risk related tweets, someone saying, "I need sex now," or substance use related tweets, someone saying, "Anybody want to get high?" Or there were general tweets in there like, "This weather is crazy," which it is pretty crazy right now. Then we mapped these tweets on a map of the United States, and we also had access to CDC data, which were county level data on HIV cases. And so we combined these data sets together, and what we found in some of the first work was that the counties where people are tweeting about things that suggest they may be at risk for HIV, where they're talking about sexual and substance use related risk behaviors, these counties where people are tweeting about things suggesting they're at risk for HIV are the same counties where we found higher HIV cases. So there was this correlation, and we controlled for a number of things in the analyses we can talk about later. But this was a first step in finding this relationship. And this was an example of AI at a number of different levels, but at the population level. So that's an example of how to do this approach with hundreds of millions of people. And we'll get to this later in terms of ethics, but it's not possible to consent those participants. So now I'm going to give an example of a smaller sample and what we did at an individual level. So this was a partnership with Intel and at UCLA with Chancellor Block at UCLA, where we recruited first-year UCLA students, and we gave them wearable devices to track their sleep and activity. We followed them on Twitter, and then we gave them weekly surveys where they would respond to their stress levels, their sleep activity, and things like that. And the question was, could we use the social media data, could we use the wearable device data to predict how they reported the experience of their week at the end of the week survey? So they take surveys at the end of the week looking back, and we would ask, how stressed out were you during the week? How well did you sleep? And we wanted to see if we could predict that using the real-time social media or wearable device data. And here, just their responses of stress and sleep patterns. Not surprising, they were doing well before finals, and here we're coming up on finals week now next week, so you can expect stress is going to increase. Same thing here with sleep. Their sleep decreased before finals, and then over the holiday break, their stress levels go back down and their sleep increases. And so we collected their Twitter data, and then we hand labeled them based on different types of sentiment. So tweets where people were expressing excitement, it was a positive sentiment, like finally done with midterms, or tweets that were expressing anger, like I hate essays with a passion. Although with GPT, I think maybe we'll see some of those comments going away. Then tweets that express emotions of fear, like I chose Netflix and sleep over studying, and now 1 hour before my test, I hate myself. So we labeled them for sentiment, and then we looked at the correlations between the tweet sentiment and their response of stress for that week. And we found that their report of their weekly stress was correlated with sentiment in their tweets in different ways. Looks like another question coming through. Go back. So we correlated, we found these correlations. So one of the problems with this approach in terms of scalability is that I talked about 500 million tweets. It would take everyone on here, probably, it would take all of our lifetime to go through 500 million tweets and hand label them. And we still wouldn't be able to finish them all. So, the promise is that machine learning could create an automated tool to learn from an expert, a human expert who's labeling these. And so that's what we sought to build, a tool that could learn from our classification and use different AI methods that we identified and attempted. And what we found was that, this was one of the early studies where we could be able to, using tweet data, we could identify whether people were sleep deprived, if they had gotten a certain amount of sleep or not. And we could do the same thing with the wearable device data. So ultimately, we were able to do this type of research at the behavioral, social, environmental levels of integrative health, looking at combining wearable device data, social media data, and survey data. And then we could develop, this is an example, we developed a dashboard which could, in real time, be able to monitor people's posts on social media, on Twitter, to be able to determine sentiment of how they're feeling. And we categorize this by university. So this is just right here, a snapshot. Don't take this to mean that students at Columbia are much happier than MIT necessarily, but this is just a snapshot. It's constantly changing. But a tool like this could be helpful because I worked with the first year experience office at UCLA, and when they had time or resources, they would give surveys to students to figure out how students are doing. And when they had additional time or resources, they would actually be able to go through those surveys and see them. But otherwise, they would just wait to hear from Student Psychological Services, the counseling center, in case, if students were struggling with anything. But if there was a tool like this available to them, or a tool like this available to parents of graduating seniors to know the school so that they're looking to attend the next year, they could maybe get an idea for what the environment is like there for students and be able to intervene. So we also developed this a word cloud and other methods. So those are examples with social media and wearable device data. Some of you may study substance use. And so here's an example of how we applied it to the opioid crisis through a partnership with we have with Google. We collected internet search, Google search data around opioids. So these are searches anywhere from people searching for Suboxone, searching from methadone to China White, street names for opioids. And then we collected actual emergency department data, emergency department visits for heroin, and combined them together to see how the models worked. And what we found was that in the cities where we found spikes in searches for opioids, that predicted 1 year later emergency department visits for heroin. And we also found it with other time periods. So these internet searches for opioids could predict ED visits for heroin. And we've gone on to do this in a number of different areas. Also, we did this work around mobility data for monitoring COVID, where we looked at everywhere you go with your cell phone, you're being tracked. Cell phone companies have that information. And we were able to work with these companies to be able to use cell phone mobility data and predict and intervene around COVID monitoring and surveillance. Another example with around the time of COVID, we looked at, if you remember when President Trump tweeted that he got COVID, we looked at the period right before that happened, when it happened, and right after. I believe it was 5 days before, the 5-day period after he said he had it, and then after that he said, don't worry about it. And so if you look at here, there's period 1, 2, and 3 in this row that says serious. Before President Trump tweeted anything about COVID, about 67% of Twitter thought COVID was a serious issue, serious condition. Then when he said he had COVID, it jumped up to 95, almost 96% of people on Twitter thought COVID was serious, a serious problem. And then about a week later, he said, don't worry about this. It's not a big deal. Don't be afraid. And it dropped back down to just about 78% and kept dropping. So this is an example of both the power of influencers on social media, as well as the effects of misinformation and how we need to be aware of misinformation online. We have done this with vaccine analyses, looking at perceptions of vaccines and misinformation. Just can go through these quickly for time. And broadly, what we do is we will work with these different companies. So CDC, Google. One example, we worked with the California Highway Patrol, and an issue there was that when there is a car crash, it typically takes 7 to 14 minutes for people to respond and first responders to be on the scene of the car crash. And there's some data that if you can cut that time by just 30 seconds, you can save more than 10,000 lives. And so we wanted to see, could we be able to cut that time down? So to do this, we worked with California Highway Patrol, worked with the chief technology officer there, and got access to the California Highway Patrol feed. And with this, we would identify when the California Highway Patrol knew about car crashes. And then we partnered with Google and Waze to look at Waze data, that user-reported data based on what's happening on the highway. And so through a mix of user-reported data and our own interpretations of the data, through psychology inferences, we were able to, by using Waze data, identify car crashes about 3.5 to 4 minutes faster than the California Highway Patrol knew about them on their feed. And so And this was with about 90% precision, just using the first or second report that occurred on Waze. So as a result of this, we then brokered this relationship between Waze and the California Highway Patrol so that they could hopefully implement these methods in their work. Then we work with other apps and other technology companies and develop different maps and tools that can help for monitoring. And we work with then government agencies and CDC for things like this. So I rushed through that as I saw some questions coming through, and I can backtrack if needed. But why don't I stop here and see in case there are any questions about anything. I think I saw something in. Let's see.
There is
Dr.
one.
Malik, do you have any?
So there's one question by Dr. Robertson. He is asking that a major concern is when these data are leaked, given, or sold to insurance companies, which then might, no doubt will, determine whether claims will be paid and for how long based on this information. So I think his question is, how do we prevent these data from being misused?
That's a big question. I'll get to that. I'll touch on it a little bit at the end with when I talk about implementation. And I think so. Yeah, why don't we hold that question for the ethics part of it that I'll get to in the end. The what's it called? The short answer. What's coming is I don't have a good answer on that. I think there are fortunately fields of study and researchers that are working on cybersecurity and privacy, and I think we'll rely on them for the best methods for data security. But I'll talk about that more in a little bit.
And then I just had a quick question. You know, you've been this is such breakthrough work, and you've created really measures, newly constructed measures from new data, and in sort of vague concepts like stress, right? So in integrative health, one of the risk factors we look at is stress, but one of the sort of disadvantages of looking at stress is, just getting a good measure. And so how many of these measures are now validated and able to be deployed in research widely?
None. So as you know, I think one of the exciting things about the Scholars Program, some of us, Dr. Kine, Michelle Kine, we've talked about and we've been working on mental health measures and pain, together with you, Dr. Malik. These are still new measures. I think it's a good time. I'll say from working with the CDC, it's been interesting where their view is more research needs to be done in this area before implementation. We are fortunate to live in the United States where we have so much resources for top measures for surveillance, case reporting for surveillance, and these measures, if these methods, the point that we make is that in low resource areas where they don't have case reporting, they don't have methods for monitoring and funding the way we do, these are ready to go in those low resource areas because they cost almost nothing, and they can be used to monitor and provide surveillance estimates in those other locations. However, here they haven't been validated. They're still very new. We are still improving upon the methods. I could go into a lot of detail in the flaws in each of these studies and where we need to go as a field. But yeah, great question. I think there's a lot of promise and excitement, a long way to go before they're implemented, I think, in the United States and in real world care.
Thank you for being a leader in getting this started. So thank you. And I just want to remind everyone, please type your questions in the Q&A box at the bottom half of your screen as we go into the second half of Dr. Young's talk.
All right. So for the second part, I'll talk about, now that we have, once we can find out and address those holes in surveillance and have an idea of either what's coming to predict outbreaks, or we know more about the population, then we can intervene. And we, especially as a social psychologist, I'm a big believer in interventions that incorporate social norms and community to be able to leverage behavior change and create behavior change. So here's an example of one of the first, and we've kept with this intervention, so I'll just describe the model. This is called the HOPE intervention, which stands for Harnessing Online Peer Education. And the idea here is that we will identify peer leaders in a certain area. So in this case, this was a number of our first studies focused on HIV prevention. So we identified Black African American or Latino, Latinx men who have sex with men, MSN, who were frequently testing for HIV according to CDC guidelines. And we then trained them, and we found leaders, so individuals who had leadership qualities and cared about helping others. And then we trained them in the psychology of how do you reach out to other people online and try to gain their trust. And we trained them in this science. And then each of the peer leaders were assigned to closed online community groups. We started this on Facebook and then ultimately built an online community in collaboration with a company. We built it called Health Check-ins, so it could be done on a secure place other than Facebook. And so within these online communities, the peer leaders will start having conversations. They'll build this organic online community, and then they will, over time, describe the behavior that we want the other patients to take on. So in this case, is HIV testing. And then as the other patients start talking about it and doing it, then it spreads to themselves and out to even outside of the group, to their networks as well. So we've done these types of studies in a number of different areas. This first study that I mentioned for HIV, these took place in Los Angeles, and we found we were trying to get these participants at high risk for HIV to request and take a self-HIV test. And we found that compared to a control group, when we went through different iterations of control groups, in this case, they were peer leaders who were providing general health information, not HIV information. And we found compared to the control group, those in the intervention group were about 2 to 3 times as likely to request this self-testing kit for HIV. And then we also found really high rates of engagement. So at the end of the 3-month study, more than 93% of participants were staying involved. And we actually followed up a year after that. And typically, this was exciting, especially the retention, because in online communities, the headline for something like this is often social media can increase HIV testing. But it's really important, it's not social media. Like right now, TikTok is buzzing, but it's not about take a technology that people are using and just throw an intervention on there and it will work. Because we had a social media comparison group, and the intervention improved compared to it. this was about incorporating psychology into the intervention is what made it successful and engaging. And so 1 year later, we found more than 83% retention still happening. And these groups, we built them from scratch, and even 10 years later, people were still, the study had long finished, but people were still communicating with each other, and they were there to help each other. You know, people would say, someone would say, I'm homeless, and someone else would say, I've been there before, here are some resources that helped me and might help you. So we were able to build these communities from scratch. And with the training given to a lot of these peer leaders, they told us they were able to get jobs in digital marketing and in other areas. So we're really excited about just the broad impact of these types of approaches. So this was an example of the first study on HIV, and because it takes place on an online community, you can see the topics that are discussed. So each of these columns is 4 weeks of the 12-week intervention. And you can see, like, friendly conversation, people started off talking about, what movie are you know, I saw a movie this weekend, or I went to a party. And those conversations decreased while the conversations around HIV prevention and testing increased, showing that the intervention was working. You can also look at the friend networks to know who becomes friends with whom over time. This is hard to see because it's squished, but the idea here was that compared to those in the control group, so different colors, 2 of the control groups, then 2 of the intervention groups, compared to those in the control groups, those in the intervention groups who became friends with other people were more likely to request and get an HIV test. We've gone on to do these HOPE studies in a variety of different areas. So here is an example, another more recent. This was a 5-year HIV study. The first one, I think, had 112. This had 900 people in it. We again found that people were more likely to take an HIV test in the intervention group. We also found reduced alcohol consumption. We've done this in Peru, so we've done it in international settings like Peru. Again, we found that compared to the control group, about 2 to 3 times the behavior change in the intervention group as a result of the HOPE intervention. Here we had the 15 versus 7%. 17 versus 7%. Then we also looked at opioid use. So these were chronic pain patients on opioids. And we found that the HOPE intervention, first of all, they discussed all kinds of interesting topics on the online community. They would talk about their pain, they talked about their coping strategy, and they talked about alternative therapies they were using. And we found that the HOPE intervention decreased their COM score, which is a sign of addiction risk. So it decreased their risk for addiction and decreased their anxiety as measured by a GAD-7 scale. The intervention participants were much more likely to post and stay engaged than those in the control group. And they reported that these kinds of things help decrease stigma associated with opioid use disorder. Some hot off the press results from a current study of patients with opioid use disorder trying to increase use of medications, their requests for medications for opioid use disorder. Again, we're finding, that in this case it's preliminary, but even more than that, 3 times as many participants requesting medications for opioid use disorder compared to a control. This is the first wave of I believe 5 waves of participants. So just some early data. We've similarly with mental health, at the time of when COVID occurred, our biggest concern was the fear and anxiety around COVID. And so immediately after lockdown, we quickly recruited. One of the great things about online research, you can quickly recruit participants. So within, I think, less than 2 weeks, we recruited about 300 people around the country with moderate to severe anxiety related to COVID. Started this in the beginning, like April 2nd, I think, of 2020, and found a decrease in anxiety. Actually, both groups decreased because we started it at the peak of COVID, but the intervention group had a greater decrease in anxiety compared to the control group, and they also were more likely to request self-coping resources and engage online. Also, this has been successful for vaccine information. We were able to get essential workers, especially unvaccinated healthcare workers, to request information around vaccination. And this was, not surprisingly, no one, I think, in the control group requested it. And so it was a pretty strong effect. Here you go. Yeah. And then finally, and maybe most relevant here, we've recently applied this. This was just published, I think, a week or two ago. We found that doing an online brief mindfulness intervention, we were able to recruit participants with sickle cell disease online, which it turned out had never been done before. And we quickly recruited 70 participants with sickle cell disease online, and then we were able to show them an online brief mindfulness intervention video, just a 20-minute video on mindfulness, and we were able to decrease many of their experiences around pain. So just in wrapping up some of the implementation considerations, I'll move just to the bottom one, I think, as it's most important for this group. Successful implementation of technology use in public health needs to involve end users at the start. It requires understanding the person. And I underline understanding the person because there are, those of you who are familiar with user experience research or informatics know that there have been methods ongoing for a while or implementation research, science research, where we interview end users and learn about their needs prior to development. But I think we need to go much farther than that, and we need to develop new methods for understanding the person in different ways. It's not enough to ask them, would you like having a feature in this app to be able to call your health provider? Because people often don't know, and they'll often just respond yes, and that can misguide development. I think we need to develop new methods, including ways of quantifying or categorizing things like nonverbal behavior among people that we haven't really done yet. And so need to have new methods for really understanding the person and developing in order to make technologies and future approaches successful. Quickly, just touching on some of the ethics. So we, along the way through all of this, conduct ethics research where we interview participants, we conduct surveys with them, because some of the work can be invasive in terms of privacy and different things. And in general, what we find, this was from a paper with about 200 patients with different medical conditions. And in general, they say, we're being tracked by Google, Amazon knows what we're purchasing, Facebook's and Meta and Instagram are doing experiments on us. You as public health researchers are presumably doing this for our social and public health benefits, so we support you. All right, and then finally, the last slide. One of the things I'm most excited about now, coming back My graduate application was about studying music and psychology, and I didn't get to do that because one, no one was doing it, and two, I think people thought I was a little crazy for trying to put those together. But now I'm no longer crazy. It turns out. Well, I might still be crazy, but this work, the NIH has issued grant applications to study the relationship of music and health, and two ideas that I'm interested in studying, and we've started doing this with pilot studies. One is studying the components of music. So I think in being around improvisational jazz musicians, for example, I think we don't have enough time to get into it, but improvisational jazz, you need to be so in the moment. Every time you perform, even though you might be playing the same song, you play it different based on how you're feeling. And I think if we can teach people to appreciate jazz and understand the structure and understand the improvisational nature of it and be able to mindfully listen to it, that experience of learning to mindfully appreciate and be in the moment in jazz, it might extend to other parts of our lives where we can be able to flow with other things in our lives and maybe reduce anxiety. And so we're working on methods and intervention methods for that. The second method is leveraging musical stereotypes. And so in a pilot study, we confirmed that people have stereotypes about listeners of different musical genres. So, for example, there are beliefs that people who listen to reggae or jazz are more relaxed or calm. And so the similar leveraging work in social psychology on things like stereotype threat and stereotype lift, you might have heard about. We can maybe take music and have people listen to music and see if it will activate the stereotypes about them and change their attitudes, beliefs, and their health. So in other words, that's the next step. We want to take music, assign people to listen to it in a randomized controlled trial and see if the stereotypes that they have about the types of people who listen to that music will become activated and it'll change their health. I need to stop here, I think, just for time, to leave time for questions. But the next steps are to design and test studies on the components of music and these genres to see if we can address areas like anxiety and stress, sickle cell disease pain, and addiction. All right, and then obviously this is what's so exciting about this work is that I couldn't have done any of it myself. All of it involves such multidisciplinary teams and collaborations, and I love it and get a chance to work with just great people with all kinds of different expertise. Thank you.
Thank you, Dr. Young. That's, for this really fascinating presentation and, pivoting from how you use and harness data to then really doing interventions based on that. So I'll start with asking about, the use of peer leaders. It seems like you do training of peer leaders. Have you done interventions which just harness, as you said, influencers with little or no training? Or do you really think that having that training, having the objectives for the intervention are key?
So we started off recruiting peer leaders who had to have a minimum level of internet experience. This was back in 2008. So that was important. And then we worked with community-based organizations. I think that's critical to leverage. I have no expertise in sickle cell. I'm just learning about it now. It's a new area. And so it's really important to work with both the researchers and the community organizations because they know what makes someone influential in those areas. So kind of by default, we already have a certain bar because we work with the community organizations and researchers who know that. But interestingly enough, we're doing something, we're just putting together an application around mindfulness and trying to use this approach to teach mindfulness, where one of the big drawbacks in mindfulness research is finding people who can do the training for it. And so we're going to be testing whether our peer leader approach can be used to scale mindfulness teachings.
That's really great. You're really harnessing social connection, and if all of social media could be like this, where we can just inject positive peer leaders, I think we would have very different outcomes. A quick question about the intervention itself. It seems like this is a really great way to do rapid deployment, and then even in terms of recruitment, for the last couple of slides you showed on sickle cell, it was really fast recruitment. And so in terms of following up after the intervention, because it seems to be low cost and efficient, do you have the interventions go on for longer than a typical study? And then when you do end the intervention, what are the effects in terms of how long they last?
I've never gotten that question. So the benefits, like you're saying, we can recruit really quickly. The drawback is that because it happens on an online community, we need to recruit everyone before we can start the intervention. So in a typical study, you might have rolling start dates and end dates. And so in that case, we would be able to, I guess, have a longer time period. Maybe we can. We typically have a 1-year follow-up, which is a good amount of time. But because we have to have everyone recruited before we start the intervention, we don't recruit 900 people at one time point, because by the time we got, person 700 through 900, we would have lost person 0 through 200. So we do it in waves. And so because we do it in waves within a typical 5-year timeline, I think we do, wave 1, year 1, wave 2, start of year 1, or end of year 1, wave 3 in year 2, kind of like that, staggered. So, and then we have a 1-year follow-up time point.
1-year follow-up is pretty impressive. So the next comment is about having the resources for the sickle cell project, if there's any public access to it, because somebody wanted to pass that along to a family that may be in need.
Oh, that's so nice. I don't know I'm guessing it would be the mindfulness video resources. So again, just what is it? Not disclaimer, but as a scientist, this was a pilot study. These were early findings. We're applying for this right now to be able to scale it. So we're happy to share these resources, but it's a pilot study, so we don't know if it, how we can't make any claims about success of it other than in the paper. But yes, if there are maybe afterward, if there's any interest or ways of sharing with people, we can share links like that. That might be helpful.
Great. That would be great. And so the next question is methodological, about selection bias related to online recruiting. And what about vulnerable populations without access to internet or who are not frequent users of social media?
So in the United States, we typically don't have that. Going back, I think one of the first studies I did was in 2008 or 2009 with homeless youth. And this was, in 2008 or 2009, 70% of homeless youth had access to cell phones and had access to the internet. So I don't think that's really an issue in the United States. In some parts, low resource settings in the world, we've done work in sub-Saharan Africa And there we just integrate different methods. So we're starting a study next month with about 3,000 patients living with HIV in sub-Saharan Africa, where we'll be tracking mobility data and different things. And there it starts by having them come into the clinic and we onboard them in person. So there you need to at least start, but still even there, they have access to WhatsApp, and it's pretty, not ubiquitous, but a lot of access. Although there are still definitely divides by race, ethnicity, culture, things like that.
It is pretty crazy how ubiquitous it is. So again, thank you so much, Dr. Young, for sharing your groundbreaking work with us. We're so fortunate to have you at UCI and to have you be a Samueli Scholar. Thank you.
Thank you so much. And again, thank you, samueli.institute and Dr. Malik.
Great. Thanks, everyone. Bye-bye.